pocket cross-linking.
Thank you, sir. Good evening, respected chairpersons, dear friends, colleagues. These are our financial disclosures. Myself and my co-author, Dr. Sri Ganesh, are consultants for Carl Zeiss Meditech. However, there is no financial interest involved in the subject matter of this presentation. So, theoretically, SMILE is considered to be biomechanically more stable compared to LASIK because you are not cutting the Bowman's membrane and it preserves the most strongest part of the cornea, which is the anterior part, intraoperatively. So, but ectasia after SMILE has still been reported, and there have been 5 case reports where ectasia has been reported after SMILE, and the standard management of SMILE ectasia which has been published is epi-off collagen cross-linking using the Dresden protocol with or without intracorneal ring segments. So the purpose of this paper is to describe an innovative technique for management of SMILE ectasia with tissue addition using SMILE-derived lenticules and pocket cross-linking. This is an exploratory study where we have performed 5 eyes of 4 patients with mean age of 25.8 years. These cases had mild to moderate degree of ectasia, and there was improvement in the BCVA of at least 2 lines. So this technique is based on a technique called femtolaser intrastomal lenticule implantation, which we described in 2015, wherein we use the SMILE lenticule and combined it with the cross-linking for management of keratoconus. Now, post-refractive surgery ectasia can be considered as keratoconus developing in an eye which has undergone refractive surgery. Hence, we thought that we can probably use the same concept for treating SMILE ectasia as well with this technique. So we obtained IRB approval, and informed consent was taken from the patient, from the donor as well as from the recipient, and serology was performed for HIV, hepatitis B, hepatitis C, and VDRL. The lenticules were essentially in this technique we collect lenticules from patients who are undergoing relaxed SMILE procedure for myopia correction, and how we choose the lenticule is basically depending upon the spherical equivalent of the recipient eye. So if the ectatic recipient eye has a spherical equivalent of 2.5 diopters, we would use a lenticule of almost the donor lenticule of almost the same power or slightly higher. And both the procedures, that is the SMILE procedure of the donor and the tissue addition procedure for the recipient, were planned on the same day. So this is how the preparation of the donor lenticules was done. The lenticule was placed on a Teflon block and was stained with riboflavin dye, and it was punched in the center to create a donut-shaped tissue. This is a recipient eye where the old SMILE pocket was opened, and 0.25% riboflavin was first injected and soaked for 2 minutes. Followed by this, the donor lenticule was inserted using a T-shaped inserter and was adjusted to the center of the corneal apex. And after this, the eye was subjected to accelerated cross-linking in pocket. So advantage here is that we are not doing any de-epithelialization. Patients are very comfortable, and there is no delayed healing or increased chances of infection with the pocket cross-linking compared to the conventional cross-linking. And the protocol used was 18 milliwatt for 5.8 minutes, delivering a total energy of 6.3 millijoules. So these are some of the cases which were treated using this technique. This is case 1, 24-year-old female, moderate myopic astigmatism in both the eyes. She had ectasia after 3 years and 3 months in the left eye. Corrected vision dropped to 618 parts. You can see in the topography this is frank ectasia. When we looked at the topography, this case was one of our earlier cases where we thought that SMILE may have a better biomechanical stability. So this case had a form fruste keratoconus-like picture, probably would not have been done, but this ended up having ectasia, and this is a 1-year outcome. Pre versus post difference map shows a flattening of 4.5 diopters in the steep K. And you can also see the ASOCT clinical picture. The lenticule is very well centered and stable. The corrected vision improved from 618 parts to 69. This is case 2, a male 23-year-old with moderate myopic astigmatism in both the eyes. His pre-op topography was actually quite normal. Post Philly with cross-linking, this patient had a very good outcome. After 3 years he had ectasia, but the outcome was very good. In the right eye, there was a flattening of 6.2 diopters in the steep K, and in the left eye, a flattening of 5 diopters in the steep K and improvement in the corrected vision. Now, this case came for the second opinion. She was a very high myopic individual, and in the left eye, she had ectasia, and this patient also underwent the same procedure and had a very good outcome of 4.5 diopter flattening with improvement in BCVA to 6/6. So this is how it's supposed to work. In the center, you have a central steep area in the ectatic cornea, which is surrounded by a flatter mid-peripheral part. When you add a donut-shaped tissue, what it does is basically it elevates the mid-periphery and causes relative flattening in the center. And its combination with pocket cross-linking also helps to stabilize the keratoconus. So in conclusion, this is the first case series of SMILE ectasia, which we have presented, which was managed with tissue addition with pocket cross-linking. Also shows another application of SMILE-derived lenticules, and it seems to be a feasible option to treat SMILE ectasia. There is no risk of extrusions or infections like intracorneal ring segments, no pain or delayed healing like conventional cross-linking. It is also a reversible procedure, so just in case if there's any, I mean, we have not seen any rejections with this, but just in case it happens, you can always remove the lenticule. However, we still need longer follow-ups to establish the safety, long-term safety, efficacy, and effects on corneal stabilization with this technique. Thank you so much for your attention.
Very nice presentation. So since these are all allograft, so what was the post-operative regime in all these patients, and for how
Sorry?
long?
Could you please repeat?
These are all allografts, right?
Post-operatively, yeah. So we start these patients on steroids, prednisolone 6 times for 6 weeks, tapering every weekly. So 6, 5, 4, 3,
Any
2, 1 for 6
complications
weeks the
you have
patients
encountered?
use.
And how long? How long duration steroids?
6 weeks.
6 weeks.
How does epithelial remodel in this patient? Does it behave differently?
So what we have actually seen that pre-operative, when there is ectasia, the epithelium on the center of the cone, basically on the top of the cone, is thin, and it is kind of surrounded by a donut shape, like epithelial thickening is there in the mid-periphery. We have seen a reversal of the epithelial changes post-Philly with cross-linking. So wherein the central epithelium thickness actually increases, and it comes out to be almost the same with the mid-periphery.
The question is, what type of riboflavin did you use? With dextran or not?
No, so this has to be 0.25%, which is approved for intrastromal application. This is the same extra one, the same which we use for LASIK extra, and it should not have dextran or
But,
HPMC.
The only thing I have is, why not use I saw that you use an Avidro system.
Yes, sir.
When you're using when you're using that Switzerland, basically, that is, why not use a 30 milliwatts or 45 milliwatts? I saw that you using 18.
Accelerated.
Yes, so
Yeah.
because this is already ectasia, so we want a good therapeutic effect. Because 30 milliwatt, again, the efficacy may not be very good. We are using 30 milliwatt protocol for SMILE extra, which is prophylactic. So because these are all already ectasia cases, so they need full dose.
Last question from my side is, now that you are showing the effect, and lot of topographies which you showed, and
Yes.
we have also discussed in the past, are sometimes you get it on a normal patient. Do you think it's worthwhile preserving these lenticules
The SMILE lenticules,
for the same patient?
same patient, you can do it, can be done. We have been doing cryopreservation earlier, but the thing is that long-term cryopreservation may not retain the quality of the lenticule. So now we have kind of stopped doing it, and we prefer to use lenticule
Fresh
from a
donors.
donor on the same day, because we have not seen any case which went on to rejection. Because when we are cross-linking the lenticule, it
Kill all
also
the
kills the keratocytes. So practically, the risk of rejection is very, very low.
I've got a couple of questions. So you're using a full lenticule, not a annulus of the lenticule.
It's the SMILE lenticule.
The SMILE,
The
it's a
size
full
of
disc,
it is
full
about
disc.
6.5.
The full disc.
Full disc. But we are modifying the shape, we are using you could see the video, a 3 millimeters corneal trephine to punch the center.
Okay.
So it becomes a donut because you
That's what
don't
I'm
want
saying.
to.
So you're using an annulus. You're
Yes,
using
yes.
an annulus.
Yes, it's an annulus because you don't want to steepen the central part further.
So how
It
does it?
basically just acts like a filler. The tissue, it acts like a filler. It just fills the mid periphery, which is
I
flat.
understand that,
Yeah.
but my concern is the amount of riboflavin. Now the central part is thin, the central cornea is thin,
Yes,
and we've got an annulus of fairly thick cornea.
it's not very. We have
So your
we maximum
the
use.
riboflavin. Have you done studies to see how far is the riboflavin, or is it being endothelial toxic?
Riboflavin will not cause any toxicity.
Okay.
We just have to soak the pocket for about 2 minutes, and then we inject the dye in the pocket for about 2 minutes, and then wash it, and then put the lenticule, and then cross-link.
Congratulations,
sir.
good paper.